Welcome to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of members of Cambridge Neuroscience. Today we are delighted to welcome Professor Tamsin Ford. Tamsin is a Professor of Child and Adolescent Psychiatry here at the University of Cambridge. We were lucky enough to welcome Tamsin to Cambridge when she joined the Department of Psychiatry in 2019. She is an internationally renowned child psychiatric epidemiologist who researches the organisation, delivery and effectiveness of services and interventions for children and young people's mental health. Today we're delighted that she is going to speak to us about the impact of Covid-19 on children and young people. Enjoy.
Thank you, and thank you for all of you who've decided to give up your early evening on Tuesday and listen to this talk. Obviously, I think it's children and young people are important, and I think mental health is important. And as Davila said, I've spent most of my career thinking about how we can do services better, but actually that master's in epidemiology suddenly is coming in very useful, not only because I have a sort of grasp of the statistics in the paper, but actually it is really essential that we don't forget the mental health impact, particularly on children and young people, because they have been so far really overlooked and they are likely to be paying a big price, as I will go on to explain. So, I promised you the mental health impacts of COVID. If we're thinking in the UK, then we need to think about the context before COVID. So the last national level statistics, official statistics on children and adolescents' mental health date from 2017. And in fact, the graph you have in front of you shows three surveys, 1999, 2004, and then the most recent one in 2017. There were screaming headlines about the epidemic. I think we'll use that term a lot less in future, but there were, we would heard about a tsunami of children with mental health conditions and self-harm, and that things were really dreadful. In fact, the statistics showed a small and significant but small increase in school-age children. And what this graph shows you is it's almost entirely to do with an upsurge in emotional disorders. And by that, I mean anxiety and depression that gets to interfere with the child's ability to cope with school, with their leisure activities in the family home, and interferes with their development. However, the types of problems you have change with age. So what you see here is amongst the 2 to 4 year olds, and that previous graph was school age children, so 5 to 16, which is all we had at 3 time points, whereas the 2017 survey is exciting because it went down to age 2, but it also went up to age 19. And what you can see in the purple is an increase in emotional disorders with age. So overall problems, mental health problems in children increase with age. And there's a swing from mostly boys amongst the younger children to mostly girls amongst the older young people, the emerging adults. And if you look, approaching a quarter of our young women were on a validated diagnostic multi-informant interview that went to everyone. We should be really proud of these surveys. They were, they're internationally excellent. A quarter of our young people have a clinically impairing mental health condition on very stringent criteria. And in fact, if people criticize these studies, they say our bar for calling a disorder is too high compared to other international studies. That signal of worsening mental health in young women has also been picked up in the adult survey. You might have noticed that the 99 survey was only 5 to 15 year olds, and that's because 16 year olds were in the adult survey, and it was felt not cost effective to survey them twice. In fact, it is really useful to have different measures and different samples, and that's why our child survey went up to 19 this time. But there have been 3 major adult surveys done by the same team, and a prior one before that. And what this study by Sally McManus demonstrated is suddenly in 2014, there was an increase among 16 to 24-year-olds, particularly young women, in anxiety, depression, and self-harm. In terms of, what predicts if you adjust all the background factors, what seems to be important in terms of mental health conditions. What you see here is the table of the adjusted analysis from 2017. So this is cross-sectional and it's very simple, but it bears out other studies. So where something's in purple, it's pretty much universally important. And what you see is ethnicity, poor family functioning and parental mental health, and socioeconomic status. And where it's in green, it's because it varies. So boys are much more prone to behavioral problems, and girls to anxiety and depression. You'll notice that there weren't amongst the primary school children, so these are 5 to 10-year-olds, and the second table is secondary school children, there weren't many predictors of emotional disorder. That's because there were fewer children to study, and I suspect these other relationships, really it relates to power. The final bit of background setting, 2 bits that I want to present, is when I meet people socially, if they don't run away screaming because they realize they're talking to a psychiatrist, they often say, well, children don't need psychiatrists, do they? And I hope I've convinced you, actually, a sizable chunk of our young people are really struggling. And adult mental health conditions in 3/4 of cases have an onset before the age of 18. So we need to look after our children's mental health. The next thing they say is, oh, but they grow out of it. And what this slide shows is children who had a mental health condition that was clinically impairing at baseline, and how many of them still met diagnostic criteria for the same condition for 3 years later when both surveys were followed up, and it's half of them. Now, I've said persistence, but I put quotes around it because we have 2 snapshots and we don't really know what happened in between, but on these 2 occasions, 3 years apart, which is quite a long time in the life of the child, they are clinically impaired. The things that predict persistence should worry us in the context of COVID too. If you look, peer relationships, problems with them predict persistence pretty much across the board. Now, that might explain some findings I'm going to bring you up later, but it underlines how important social relationships are for children and young people, and they have been mightily disrupted with school closures and lockdowns. The other thing is family functioning and psychological distress in the parents. To be flippant, a family can probably only be as happy as its unhappiest member. And there is different work that I'm not going to present today that shows that the impact of poor mental health in either a parent or a child impacts on the rest of the family. There's a bi-directional relationship. Final bit of scene setting, which is really very worrying. It comes out of the Cardiff group led by Ruth Sellers, who examined children who were born in the 1990s, children born in the 1970s, and children born at the turn of the current century who had mental health problems or didn't in childhood, around about the age of 8, and then looked at their outcomes in terms of education and health in their teenage years. And it seems to get worse with each cohort. So we have a real cluster of really unfortunate things going on before COVID hit, which is we have worsening children's mental health, and we have worse outcomes for the more children who are struggling with their mental health. Now, our classification system in psychiatry and other mental health practices comes in for a lot of stick. Even those of you who are nothing to do with mental health will have seen DSM-5 causing an absolute storm of discussion in the media a few years ago when it first came out. And you don't see that for cardiology and respiratory medicine or gastroenterology. And it's partly because we use terms like anxiety or depression that are universal experiences to a certain extent to also describe the situation where the experiences related to anxiety and depression or the challenging behavior are such that they tip over into impairing development in children or preventing someone's ability to function. And Jeffrey Rose, so people much more eminent than I am, would argue that actually all of medicine is like that nearly everything is on a continuum, and we stick a cut point on it and say, past this point, you have hypertension or you have diabetes, for example. And these slides are to remind us of that. So what you're looking at is the graph on the left hand is the child's report in 2004 on something called the Strengths and Difficulties Questionnaire that tots up all your problems, the parent report and the teacher report. Now, what I find fascinating as an epidemiologist is the fact that these graphs are so different, despite the fact that all three informants are asked exactly the same question. In fact, the only difference between the parent and teacher form is a P or a T in the top left-hand corner. The blue arrows denote the clinical cut points, and you'll see there's no kind of separation, there's no kind of difference between a child just underneath it and just above it. What will make the difference is the social context that that child is living in. And actually that is what COVID has really badly hit. When COVID first happened, there was quite rightly a huge amount of research, policy and practice attention on how to manage the acute illness. We desperately need a vaccine, we desperately need effective treatments. But actually it was very clear for those of us who work in mental health that there was going to be a huge impact on mental health as well. And mental health services and also mental health research are grossly underfunded. And if mental health is the Cinderella branch of medicine, children's mental health is the Cinderella branch of the Cinderella branch of medicine. To the point that children, but also those in low socioeconomic status, women who are often the primary caretaker, and those from ethnic minorities were highlighted in this multidisciplinary paper that came out of the Academy of Medical Sciences and MQ saying, let's not forget mental health. The word unprecedented has been grossly overused, along with R-factor epidemiology and probably epidemic and pandemic over the last few months. And there is a lot of noise out there. Paul Fletcher's talk a couple of weeks ago did a fantastic job of collating patiently the evidence in relation to people who are acutely unwell, and then in terms of the population impact. I just want to draw your attention to this heroic living systematic review, which doesn't actually involve children, but it gives you an extent of the problem about poor quality papers out there. So this is a group from McGill in Canada who are doing a living systematic review, and I had to check this every so often, and I can assure you the number of abstract screens are going up by 1,000 to 2,000 a week. So as of this morning, they have screened 27,500 abstracts. They have found 300 trial registrations. So these are mental health interventions related to COVID. But they have 3 reviews, and they have only found 14 papers that relate to what I'm going to talk about, which is the impact of COVID on mental health, that are sufficiently rigorous to include in their study. In terms of how factors are implicated in change of mental health during COVID, there's a few more, but it's still very few. There's a lot of noise out there. So engage your critical appraisal brain whilst reading papers. And this is partly because policy and practice were operating in a real data gap, particularly in relation to children. And there is an issue about time versus quality. You don't need to go through ethics or governance in order to sling up some questionnaires on an online survey. And it does give you some useful information until you can get something a bit more rigorous going. So I don't mean to say we completely get rid of some of the convenience samples that are around, but we need to be aware of the potential for bias. So, for example, large does not equal better. There is this myth that because something has 52,000 people in it, it's a really good paper. But if in a country like China, which this example which I'm coming from, which has actually a gender ratio skewed towards men and boys because of the one-child policy, there are 65% women, you've got to wonder about how representative it is. And certainly it's not going to tell you very much about the mental health of men. If you know about your background population, you can wait, but waiting doesn't get rid of bias. And the problem about these non-probability samples is they lack a sound theoretical basis for statistical inference, which all the assumptions that underpin the statistical analyses we do relate to the probability of people being selected. And if you don't know what that is, you don't know who has seen your invitation online, then you are operating blind. That doesn't stop people doing it, and it's not necessarily totally invalid, but we need to be aware of when we're breaking assumptions. I'm not going to dwell on the changes in mental health in adults. These are from the McGill population, but suffice it to say, in young adults, depression seems to be more of a problem than anxiety. In those with systemic illness, anxiety seems to be more of an issue than depression. Perhaps that's not a surprise, and perhaps it's adaptive. And in amongst middle-aged people or established adults, so the Ausbach mums are in their early 30s, actually there are some studies that suggest the population is not doing that badly. But some of these are very small, particularly the ones on university students. One of the better ones, which Paul mentioned very briefly, and I'll talk about in a bit more depth, comes from the UK, so directly relevant to this country, and it relates to the UK longitudinal survey, which has up to 9 waves. So it recruits people at the age of 16, and it goes back every couple of years. And therefore you have to keep getting in 16-year-olds, because last time 16-year-olds are now 18. But some people have been in it for as long as 9 different waves, and it covers the working age adults. On the general health questionnaire, which is a 12-item measure of anxiety and depression symptoms, what we can see, and of course there are no youngsters younger than 18 who are in that data set, is over the last 10 years or so, there has been a deterioration of the population's mental health. But for everyone, it's accelerated between the last data collection and data collected in May. The implication being that COVID has impacted on these people's mental health. Alarmingly, those who are younger show a sharper acceleration. So that's 16 to 24-year-olds, and to a lesser extent, 25 to 30-year-olds, sorry, 18 to 24-year-olds. And again, young women seem to be having much higher rates than young men within that. Women are high risk rate across the age span. And parents of young children were also a newly emerged group. Those of lower socioeconomic status were more vulnerable. It's a very common finding. There's lots of epidemiological data that links debt and financial difficulty to poor mental health, which should really worry us. But interestingly, what this survey showed was, although those who were unemployed had higher rates, the deterioration in mental health was worse amongst those with a job, particularly if they were of lower socioeconomic status. What about children then? I'm supposed to be talking about children. Well, there is a real data gap. So until last Tuesday, we had almost no data that had pre or post COVID, pre and post COVID comparison data. The slide shows data from a small local Cambridge-based study, which went back to children that had seen sort of 18 months ago on average. They're relatively affluent. Those rates of free school meals are quite low. Interestingly, on a detailed measure, the RCAS, Revised Child and Anxiety Depression Scale, which has more questions about anxiety than depression, there was no evidence of an increase in anxiety, but there was an increase in depression symptoms. And that's very striking for children of that age. Depression is not common in prepubertal children. Then more recently from Bristol, some colleagues had collected data from 1,000 students in year 9, so they're aged 13 to 14, in October, and they went back to them in April and May. The main sort of pandemic related concerns were worrying about friends and family and worrying about the mental health of friends and family, actually more than themselves. And then in terms of depression, anxiety and well-being, there's some really interesting findings. So what the graph in front of you shows is for those who were struggling above cut point on this short scale in October, they seem to be doing significantly better in May with non-significant changes in those who appeared not to have any depressive symptoms worth speaking about. You see the same pattern in anxiety and also in well-being. And that's really interesting. So we shouldn't assume that lockdown has necessarily been bad for everyone. And I'm going to come back to that later. The other study in terms of children that you might have heard of is the CoSpace study run by Kathy Cresswell. This has been an open online survey. Despite huge efforts, they have quite a bias in terms of ethnicity and socioeconomic status, so primarily white, primarily highly educated and more affluent than average, what Miranda Walpert would call a weird sample. But that said, there have been some repeat measures during COVID, and that can at least tell us what's going on with those families at that time. It won't surprise anybody, and I imagine there are lots of people here who tried to do it. When you're both trying to work and homeschool your children, it's very hard and very stressful, and lots of parents were finding it really difficult to balance that. But in terms of mental health of the children over 1 month, that's sort of round about April to May to June, parents' reports of children, so that's primary school age children, was worse mental health across the board. So emotions, behavior, and their ability to sit and concentrate. For young people, the parents reported fewer emotional difficulties, although this was on the Strength and Difficulties questionnaire, which is not the best measure for emotional difficulties. And parents, it must be said, are not the best reporters of their children's internal feelings either. Parents thought young people were more restless, but the young people themselves thought they were doing fine. Those who had special educational needs or disability or a pre-existing mental health condition, again, decreased emotional difficulties, which is interesting, and I think a damning indictment perhaps of the support these children get at school. The Oxwell survey is huge, more recently reported and perhaps less well known than CoSpace. This is in its second year, and whilst in order to be able to do more with the data, they cannot link responses back to individuals, but they do have a variable saying, did you fill in this questionnaire last year? So they can get back to a set of youngsters that they've got data on in 2 years, which suggests an increase in self-harm, quite an alarming increase in self-harm. But it's very large. It covers 237 schools, so there is a frame of reference. They know who they invited, across 6 counties in the south of the country. And the data were collected in June and July. So as things were beginning to look like they were easing, quite a lot of youngsters are struggling to sleep, particularly the older youngsters. Now, that could relate to lockdown, it may not. One of the main things that people are worried about are doing well at school and college, which is interesting and worrying. These children have had a very disruptive education, and I really feel for those who are possibly facing GCSE or A-level or the equivalent in other nations and not yet knowing what they're aiming at, as well as the teachers who are trying to prepare them. There's also been quite a lot of increased risky behaviour. So these questions were only asked to sixth form students, so year groups 12 and 13, and it won't surprise anybody that the students in year 13 were more likely to report drinking, partly because they're legally allowed to do so, but we saw the same pattern for gambling, which is worrying, and also for illicit substances. Young Minds did an online survey of their people with lived experience who are linked in with them, about 2,000 young people, and you'll see that most perceive lockdown to have made their mental health worse. These young people were between 13 and 25 and reporting very early on in the pandemic. So perhaps that's less surprising, and I'd be interested if they went back now and repeated their survey. And then similarly to CoSpace, there is UCope, which is run out of Imperial for young people aged 16 or over, and just illustrating the massive disruptions that this age group has had to deal with. So 41% with ongoing healthcare needs reported disruptions to accessing services, and that was even higher if it was mental health care. A quarter had changed their living situation, 3/4 had either education or employment changes, and a third facing decreased income. So as of last Thursday, we now have published official data from the National Survey in 2017 that I started this talk talking about. And the slides that I'm now presenting come from the official briefing. So thanks to colleagues at the Centre for the National Centre for Social Surveys, the Office for National Statistics, and NHS Digital, as well as Tamsin Delgado at the University of Exeter Medical School, all of whom worked very hard to get this survey off the ground. So the original sample of 2 to 17-year-olds, there were just over 9,100 children, and we went back to everyone who had said, yes, it's fine to contact us again. However, there had been no keeping in touch exercises because this wasn't planned. The original sample frame was the MyDesk database of GPs, GP registrations, and it's not as accurate as, no database is ever perfect. We updated it as best we could, but there were quite a lot of people we couldn't contact, and there were some people who declined to get involved. So our final response rate was 45%, which is not bad for an email, which was the initial way of contacting them, with telephone chase up if we had a telephone. And interesting, the telephone chase up was not to conduct the questionnaire over the phone, as in previous years. It was to try and get people to answer it, because we had about 60 items in there, and that would have been a long telephone call. It had two aims: comparing the mental health of children in 2017 with those in July 2020, and describing how life is for this sample that we know an awful lot about. Now, there is a kind of 70-page report, and I'm not going to try and throw it at you all in 5 minutes. I'm just going to handpick what I think are the important issues. One important thing to realize is that in 2017, we had these world-class, multi-informant, standardized and validated diagnostic interviews that really they combine very structured information with semi-structured information, and they were all clinically rated, and there was no screen. Everyone had the assessment. We couldn't do that this time. So what we used was the Strengths and Difficulties questionnaire, which I've already mentioned. Now, this is used all over the world. It's 25 items with a 10-item impact supplement, which I think actually is almost more important than the questions about emotions, behavior, and how you get along with people in the main body of the study, the main body of the questionnaire. And in this survey, we had the parents of all 5 to 16-year-olds were sent it. 11 to 16-year-olds completed it. So for those aged 11 to 16, we had 2 informants, and those aged 17 to 22 just completed it on its own. There is an algorithm developed from the initial survey after preliminary work on clinical samples that will then estimate the likelihood of a unlikely, possible, or probable mental health condition. So that if that child underwent one of these standardized diagnostic assessments, how likely they would be to have a mental health condition. So the comparisons between 2017 and 2020 need to be done on this SDQ measure, not between the report in 2017, which uses a different, more sophisticated measure. And to give you a sense of, to be scored unlikely, you need to score less than 3 on the emotions or behavior subscale, or less than 5. I'm just checking the pictures of me and everybody were over the slide I was reading. Less than 5 on the hyperactivity subscale, and you have to have no impact whatsoever. And if you fall into that bracket in a population sample, it's less than 0.5% will turn out to have a mental health condition. Whereas at the other end of the extreme, you have to be over the 95th centile for each of for one or more of the subscales that feed into the total difficulty score, and to have an impact score that's more than 2. And obviously those who are possible are in between. Now the specificity, the accuracy of saying this child doesn't have a condition, and that being the case, is very high. It's in the high 90s. The sensitivity, how accurate this is at picking up a disorder, is lower. So the bottom line, rates of probable mental disorder in 5 to 16-year-olds have increased. So using the SDQ, it's gone from 1 in 9 to 1 in 6. And interestingly, it was 1 in 8 in this age group using the diagnostic measure. So if anything, the SDQ seems to be underestimating. Now, if you think of a child, of a class of 30 children, that will be 6 children in every class. That's quite a workload for teachers to be dealing with. Young people over the age of 17 had particularly high rates. Now, we have nothing to compare this to because we didn't have young people aged 20 to 22 last time. But again, young women, over a quarter this time. Young women are a high-risk group. We need to worry about them. 2/5 and approaching a half of young people reported that lockdown had made their life worse. And that was much more likely if you had a probable mental disorder. That's no surprise, but it's important to get out there, I think. Just over a quarter, approaching a third, mentioned having sleep problems. Again, much more likely if you have a disorder. Now, cross-sectional data, we don't know what's chicken and what's egg. If you're anxious or depressed, you're much less likely to sleep well, but equally sleep impacts heavily on mood. And if you're very overtired, the world looks much worse. Disruption to access to services was also evident. Only a quarter had sought help as usual. Interestingly, of emerging adults with a probable mental disorder, more than a quarter didn't think they needed any help for anything. So we're not seeing loads of demands amongst the worried well, but 5% reported they didn't seek help for a physical health concern. Over a fifth that they didn't seek help for a mental health concern, and a similar amount for both. So we've got, as people have assumed with the work that Rudolph is going to present in a future talk, people have talked about reluctance to seek help and what that may mean for people's health. We are seeing it for both mental health and physical health, and there were similar reports from parents. Loneliness is another really important risk factor for mental health conditions, particularly depression, particularly in teenagers. And as you'll see, 1 in 10 children and young people in the whole population reported that they always or often felt lonely. And that was much higher amongst the youngsters with a possible or probable disorder. And sorry, the probable disorder is grey, it's disappeared. So, depressing statistics, what should we do? I think we need to try and keep schools open as much as we possibly can for 2 reasons. Firstly, children are less susceptible to get the virus. It makes them also less likely to transmit it. And provided the community levels are not too high, the harms to them in the longer term for missing education are much higher than the risks of COVID to them. The other thing is when the schools were not completely closed, the take-up amongst vulnerable and key worker children was very low, and that meant there were lots of vulnerable children who were just out of the eyes of the network that can normally keep an eye on how they're doing and keep the family on an even keel. So we need regional and local multi-agency planning about how to manage that if it does happen again, in order to stop these children sort of disappearing off radar and very bad outcomes. Services have had to move dramatically towards offering what they can remotely. And I think for some families, it's worked really well. And actually there are some families that seem to enjoy it, but there are concerns around safeguarding, confidentiality, and other issues that we need to work out. So I think when things open up, we need to co-produce guidelines for the best practice in remote mental health, because if it works for families, it would reduce travel time for both the families and the practitioners. However, it won't be a panacea for everyone, and we need to know for whom it works and how best to do it. And we really need data. We've still got a massive data gap with children. So we are hoping to do 2 additional waves, questionnaire waves with the national survey. We have a bid in to link the national survey data with the national pupil database and the NHS statistics like hospital episode statistics, which will be fantastic way to keep an eye on these children who are really well characterized going forwards, but we still have a massive data gap. Children who are likely to be very vulnerable at the moment are those with pre-existing mental health conditions. And there is hint in the data now, this hunch that some of us had that for some lockdown would have been a blessing as it took them out of a situation they were struggling to cope with. But we all know if you avoid anxiety, it becomes harder to deal with it later. And I suspect we will see a spike of persistent poor attendance at school, with the risk to mental health and educational outcomes that produces. There are also those who will have had an adverse experience during lockdown, either because they've had the infection or they've been bereaved or seen a relative very unwell. And sadly, the risk for domestic violence, abuse, and as some of the data I've shown you, risky behaviour on the part of young people themselves may well have jeopardised their mental health. There are going to be more children living in families with financial strain, and we know that's toxic for both parental and child mental health. We are all influenced, our behaviour and our mental health are influenced by what's going on around us. And actually, I keep being asked, you know, are we seeing adaptive changes here? Well, I think by the time we get to July, which is when the national survey data was gathered, I think adaptation could have been expected to have happened over 3 months. And the more negative influences you have, the more you might get pulled over to this quadrant, whereas we all want to be full of positive influences and positive mental health or behaviour in terms of schools. So there are some really simple, cheap things that schools can do to support children's behaviour, and I'm not going to go into them in detail for this audience, but for those of you who are interested, there are 3 systematic reviews that underpin this practitioner advice, which is available via the Education Endowment Foundation website, and I'll make my slides available for those who want them afterwards. And I think schools need to focus on what they can manage directly. So relationships, teacher-pupil relationships are hugely important, but also so are relationships between pupils. The teaching and learning environment, there's work recently published by Pravita Pathale from UCL that shows that school climate accounts for about 1/3 of the range of mental health and well-being in a school. That's something that individual teachers and schools can do something about, and trying to promote positive attitudes and positive self-concepts. There are other things that you can be aware of and maybe influence a bit, but there are certain things that you cannot do anything about. And sadly, we tend to sort of bemoan this bit and forget to deal with the bit we can deal with. Finally, I want to talk about some really excellent work from a colleague called Helen Minnis at Glasgow. So she conducted a small study in March, April at the beginning of lockdown, and then they went back to the same people in June and July. It was a combination of qualitative in-depth interviews with parents and professionals working with children, including things like social workers and people like social workers and the police. And then worked with the findings with infectious disease modelers to co-produce a plan to try and mitigate the pressure on families, because what they demonstrated is where people have resources, where they have adequate housing, they have good Wi-Fi, each child has access to a device so can log on and access any lessons at school, and the school is providing some lessons. Actually, after initial levels of anxiety, they settled into a regime and actually found that lockdown was valuable, precious, quality family time. And actually they were in a virtuous cycle of coping better. I have worries about some of those families when things return to normal, but you know, lockdown was not universally reported in the national survey either as a negative experience. However, where housing was poor, financial insecurity, parents who were struggling to keep their jobs, perhaps not able to work at home, or perhaps not with decent Wi-Fi or enough equipment for everyone to do what they needed, they were more likely to get stuck into a vicious cycle. And the police and social workers reported an upsurge in domestic violence and abuse and poorer mental health in parents. and in children with substance misuse and other not very helpful ways of coping. So the idea is, let's try not to put so much pressure on families that are struggling to cope. So the ideal is to keep the schools open full time with everybody going. Where that's not possible, well, can we have schools with bubbles so that you have part of the school in and they're separate from everybody else? So at least there is some schooling and some respite for families so they're not crammed in small places all the time. And if you can't do that, is there a grandparent or a trusted adult that you can have a kind of closed cluster with so that the childcare is shared out and the pressure is off the families who are struggling to cope anyway, and that isolation at home is the last possible resort, or only used for those families that are dealing with it. Really interesting work and a really lovely example of policymakers, researchers and the community working together to find a solution, because of course Glasgow has a lot of very deprived families. So just to sum up, we have a real data gap, and we should be alarmed by the rates of probable mental health conditions among our young people, particularly among young women in their late teens. But the vast majority of kids are doing fine. Then there will be those who even before lockdown were suffering. And I think what's happened is this vulnerable group has got bigger, and that's where we really need to target our resources and our actions on supporting those who have needs, but also trying to reduce the size of that vulnerable group. I will stop there, and I've got some sources of information and some references for those who want the slides. Thank you.
Thank you, Tamsin, for that very informative talk on the impact of COVID on young people. Don't forget to join us next week when we will welcome Professor Carol Brain from the Department of Public Health and Primary Care here at Cambridge. Carol will be speaking to us about population studies and ageing brains in a time of COVID. You can sign up on the links shown here. We'd like to thank you all for joining us. Please follow us on Twitter at CamNeuro to keep up to date with all that is happening in Cambridge Neuroscience. And see you soon.